Great, thank you very much. So we're seeing more and more of these fractures, so I thought it'd be a great thing to talk about. Paraparasitic humeral fractures are still in the infancy of understanding these things compared to some of the fractures you see in the lower extremity, but I'll try and go through these as much as possible. These are my disclosures. I don't have anything particularly relevant to disclose to this topic. If you look at the graphs of paraparasitic fractures, and these are all comers, so all different bones, you can see that the rate is going up dramatically with time, and certainly we see that in the upper extremity. The number of fractures we're seeing in the humerus and in the acromion, which is another separate topic, is dramatically increased, and there's really no question about that no matter how you look at it. If you look at our experience at our hospital, this is a single hospital in Banner University Medical Center, we identified over a relatively short period of time 76 patients who had paraparasitic humeral fractures. And in the old days, a series of humeral paraparasitic fractures of 10 or 15 patients would be a big series. And we obviously have far more than that, and other institutions are the same. So the incidence of these is definitely going up. We also found that patients with a short stem were significantly more likely to have a loose prosthesis after fracture, which would make sense if you think about that, and they required more surgery. I'll talk briefly about these shorter stems, which have certainly become very popular. I think it was initially hoped, if not expressly said initially, that the incidence of paraparasitic fractures would be lower around a shorter stem. And there was some biomechanical evidence to support that and some early anecdotal evidence. I think, unfortunately, that's not the case. And it's hard to be sure because, we don't know the denominator out there. But certainly, I would say most of the paraparasitic fractures we're seeing now around reverses are around these shorter stems. So it hasn't panned out that we're going to decrease the incidence of fracture by using these shorter stems. We've seen even the resurfacings have fractures around them. We have 5 or 6 of those already. So it doesn't seem to be the panacea that was hoped to be, unfortunately. The problem is with these shorter stems, if you leave it in place, they're very limited bone around to fix. If you take them out, you have this shell of proximal bone that's really difficult to deal with. So there's issues there. With decision-making about humeral paraparasitic fractures, these are the questions you have to ask yourself or ask your patient. Was the prosthesis functioning well? When we have a patient come in with one of these paraparasitic fractures, I always ask the resident, did you ask the patient before you fell and broke your arm yesterday, was your shoulder functioning well? And they usually say, no, but we got a CT and an MRI and a PET scan. And I said, no, but we have to go back and actually ask the patient, was that joint functioning well before you fell and broke it? Critical part of the information. Is the humeral stem solid or loose? That's always important. Where's the fracture? What's the alignment? Is it acceptable? The patients have any healing potential? And what's the bone stock like? So these are the kinds of things that we use for decision-making in this area. If you look at this fracture here, it's a long oblique fracture, lots of bone exposed. The alignment's fine. If it healed like this, it would be okay. The shoulder is in place, functioning well and solid. This is one you could probably treat non-operatively. And all these things are part of your decision-making. And you leave this one alone, and it does pretty well long-term and heals. And that's a radiographic malalignment, but functionally meaningless for the patient, and they did pretty well long-term. Here's another stem. This is a patient who's unfortunately got relatively poor healing potential. They're rheumatoid, they're on steroids. We've got significant displacement at the fracture site, poor biology, even though the stem appears to be quite solid. The bone stock's not the greatest, so this is a bit of a challenge for decision-making here. This was actually left like this for a couple of weeks, and this position didn't improve. There wasn't much sign of healing and a lot of gross motion there, so we decided this is probably one that we should fix. Also, if you look up top of that red circle, there's very little bone proximally around this stem to get any kind of screws into. This is a patient we left the stem in. We did a fixation with allograft. So we found allograft use is very, very helpful in these individuals, and you can get a coracal strut and literally bolt across into it from the opposite side of the humerus, and it really gives you a lot of better fixation up top in these tough situations. And this patient went on to heal. Their shoulder was far from perfect, but overall they were pretty happy with the results, and their fracture healed fairly promptly. What about other more interesting complications? This is a lady who had a reverse for cuff tear arthropathy, which she was very happy, was working very well, and she was ecstatic with it. Then she was in a car accident, broke a bunch of bones, as you can see here at the bottom. This is her x-ray when she was referred down about a week later. You can see that not only is the position probably unacceptable, but also she has to walk on this arm because she has an associated talus fracture, and we know the treatment of those is usually associated with a long period of non-weight bearing or touch weight bearing, a bunch of other things as well. So she has both local indications and systemic indications to have this fracture fixed. It's a long oblique fracture or spiral in nature. You could probably get some good lag through this, and there's enough bone up top to fix. And so probably standard techniques would be good for this patient. We also, remember, she's fairly fresh in the post-operative period, so you'd like to continue with her shoulder rehab, which you can't really do if you're in a splint for your humeral shaft fracture. So she was lagged, cerclaged, and things went pretty well for her, and she healed up quite quickly. We were confident enough in the fixation to allow this patient early weight bearing for their associated talus fracture. What about short stems? That's a major issue. This patient has a short stem, has a fracture on it. You think, well, this isn't too bad. If we leave it alone, maybe things will be okay here. And that was tried initially, but you can see with time it just displaces more. The issue here is if you try and take this stem out, you have this little shell of bone up top that's often cracked and broken, very difficult to deal with. If you leave it in, you don't have much room up top to put screws into. It's a real challenge technically. And this is the kind of decision making, again, that we go through. This patient had good biology, etc. So she needs something done. We found that a plate with flanges on it, and almost every company now has a plate with different flanges on it, makes a big difference up here. You can actually get around or corral that proximal fragment with those flanges, and it makes a big difference in these short stem fractures where it's very difficult getting proximal purchase. And this is just an intraoperative picture of that, and you can see how, and some of these are actually contourable intraoperatively, so once the plate is fixed, you can use bending irons to actually bend and crimp the flanges to stabilize the fracture. And this patient did well long-term and had really good return of function. What about more complicated cases? This is a patient that had a hemiarthroplasty that was not functioning well, so it was a crappy shoulder to begin with. Then she fell and broke around it, and you can see that there's a significant displacement here. Bone stock up top is poor. This is going to be a major revision case where you're going to revise the proximal stem. You're going to put a reverse in up top because you can see that she's already got wear of her acromion from the long-standing poor functioning hemi, and then you're going to have a lot of issues here. CT scan just confirms the fact that you're going to have issues with bone stock, and this is a major revision obviously for this patient. You can see how little bone there is left up top once you get that stem out. The glenoid is pretty straightforward, and it's one of the nice things about working in this area is in humeral-sided problems is usually the glenoid's in pretty good shape for you to fix. This patient has two separate cortical struts, a bunch of cerclage, and of course you have to be very careful putting this cerclage up around where the radial nerve is, or you run into major problems. You can see intraoperative pictures here, and then down the road she heals up pretty nicely and does fairly well. So there's a gradually increasing degree of complexity depending on whether your stem's solid, what kind of bone loss you have up top, like a Vancouver B3 or with very little bone stock, etc. You have to be prepared to use other things to make up bone, such as in this case. And this is her healed about 6 months later. She actually had dramatic improvement in shoulder function compared to what she was like before, which she was quite grateful for. So in summary, I'll say if the stem is stable, you should fix the fracture, fix it well. Usually a 4.5 compression plate is available. There are some rudimentary upper extremity paraprosthetic plates out there that some people are working on. They're not readily available yet, but if you have a company that makes one, I'd encourage you to use it. Make sure you get good proximal fixation. A cortical strut has been a major benefit for us in these situations. There may be some advantage to a plate with flanges on it if you're trying to deal with one of these short stem fracture situations. If the stem is loose and shoulder function was poor beforehand, then revise it. There's no point in doing a big operation and getting a patient back with a poor shoulder function they had before. This is an opportunity for you to make it better for them, and certainly you can have a very grateful patient if that's the case. Early motion and weight bearing should be a goal, especially for elderly patients. And lastly, and this is just important to remember, if they have this kind of fracture, remember bone health referral is often appropriate. So I thank you very much for your attention.